Good afternoon. It's almost a graveyard session. I'd just like to thank the organizers for giving me the opportunity to speak, and these are my disclosures. I'm going to be talking about natalizumab as an example, and alemtuzumab, and I have conflicts because I've been involved in the development program of both those products. So, I'm here actually to represent people with the disease, and I'd just like to thank Christoph Thalheim. Hi, Christoph. For asking me to speak on behalf of the European Multiple Sclerosis Platform. This is a lobby group for people with the disease. And he asked me after he heard me speak about the window of opportunity at the European Neurological Society meeting. I'm actually not sure I'm the best person to be talking on behalf of people with the disease. Are there any people here with MS? So I'm going to not pull any punches. I'm going to possibly upset you a little bit. And we've all seen diagrams like this. And the question is, when does MS present? So we all know that when you present with your first attack and you've got large numbers of lesions and you've got brain atrophy, you do worse than if you present with your first attack and you've got few lesions. But I just think you're very lucky if you present with your first attack and have few lesions. What causes you to present is a lesion occurring in an eloquent pathway. If your first lesion is in an eloquent pathway, you've come to the attention of neurologists early. If your 50th lesion is an eloquent pathway and you've had 50 lesions before then, not to mention the hidden lesions, you're already disabled. And the evidence that you're disabled by the time you come comes from a post that really influenced me a lot. I saw this post at the American Academy earlier this year. And this is a group of patients with MS in Argentina. And they went back to their final years of school and they found out that people with MS, matched for age control and socioeconomic status, had cognitive impairment in their final 2 years of school, even though they developed MS many years after leaving school. So by the time you present with your first clinically isolated syndrome, you've had this disease for years before. It's like Alzheimer's disease. By the time you present with your dementia, you probably had pre-symptomatic MS for 5-10 years. And what they did show is that your age of onset predicts your fall off in school marks. So the earlier you presented to the disease, the worse you did in your final 2 years at school. So by the time you present with CIS, you've already acquired disability. And we know that because atrophy has been now shown to occur very early on in the disease, and it's present in CIS, and there has been a publication, and Klaus spoke about it, even in people with RIS, radiologically isolated syndrome, asymptomatic MS, already have cognitive impairment and brain atrophy. So if you've got MS, how do you feel about that? So this is just one cognitive study, just showing by the time when you present with the very earliest manifestation, you already have cognitive impairment in at least 2 domains. So you can just dismiss this, but this has impact because, I won't go through that slide, this has impact, and this is the real impact of this disease. This is on jobs. So this is Danish data, but it's pretty much the same across Europe. So 10 years after diagnosis, 50% of the MS population are unemployed. And why are they unemployed? Because they're probably unemployed because of cognitive impairment, and they're unemployed with an EDSS of 3.5. So all of us who know the EDSS, 3.5 is a level where people are still very mobile, they don't have much physical disability, but clearly the cognitive issues are stopping them from working. So if we're going to have a two-step approach and wait for people to become disabled physically before we start the treatments, we've really missed the boat. And as you know, quality of life also deteriorates with disability. So if you want to maintain quality of life, cognition, and people in employment, we really have to treat this disease earlier than later. And this is just a quality of life study. This is the UK general population assessing what they think is quality of life for people with MS. And what's scary is when you're quadriplegic, lost upper limb function, the average British citizen thinks that your quality of life is worse than death. So that's a sobering thought. So we have this two-step approach, and this is just some data that's come out of the Italian group in Rome. There's been data from the MS space in real life. This is taking people now who've been given a first-line therapy and then switching them because they're not responding to that treatment, either to a highly active drug, more effective drug, and this happens to be natalizumab, or switching them across the classes. So from interferon to GA or from GA to interferon. And you can see that you're much more likely to be rendered activity-free if you go to the more efficacious drug. All right? So the question is, and I'm very worried about it because whatever the European regulators put in licenses, national funding agencies and payers take up. So what we have this scenario, we may have to put people through multiple first-line, less effective therapies before they can access more effective therapies. And how much do you lose waiting for that to happen? So I got to think that MS is actually a dementia, and I went into the definition of a dementia. And this is a standard definition in the psychiatry. This is from the DSM-3, the DSM-4. Dementia is a loss of mental ability severe enough to interfere with normal activities of daily living, lasting more than 6 months, can't be present at birth, and is not associated with loss of alteration of consciousness. So normal activities of daily living refer to physical, mental, social, occupational. I haven't got time, but this ticks every box in MS. Lasting more than 6 months ticks a box, not present at birth ticks a box, and it's not associated with loss of alteration of consciousness. So actually, in reality, multiple sclerosis is a dementia. We don't think of it as a dementia because our stereotype is a little old lady in an old age home who forgets her family and has an autobiographical loss of memory. But I think if we look at the impact of MS on people's functioning, we begin to realize this is a dementing illness, and it's dementing from a very early age, from a very early stage of the disease. So educating people on our social network, people begin to agree with the fact that it's a dementia. So do you agree that these are people with the disease voting, saying that it is? And do you think MS should be allowed early effective treatment to prevent cognitive impairment or dementia? And obviously people who have the disease would like that. And the pathological substrate is pretty obvious. If you look at the pathology of MS, it's definitely there. It's a disease characterized by loss of axons, neurons, and the MRI and the pathology data supports this disease as a disease, the progressive disease of axons and neurons. So is there a window of opportunity? So I think there is a window of opportunity. It's not only time limited, it's also disability limited. So by the time you become disabled, you probably missed the boat. So the current strategies are the two-step approach. You can either start what we would call safe and smooth, and the majority of people will be partial or non-responders. And so by the time they get to a more efficacious drug, they've lost a lot of reserve. Or you can give them the option. I'm not saying we should force everybody to have these therapies. Give them the option of taking a more effective therapy earlier. And I agree, we may have the wrong hypothesis. We may find that all these people that we flatline in terms of disease activity will come back in 20 years' time with secondary progressive disease. And George and I have discussed this many, many times. That is a possibility, but are we prepared to make people wait 20 years before offering this opportunity? And that's a question that we have to ask, and people with the disease have to ask ourselves about the 15 or 20-year experiment. So I'd like to give you two scenarios because this is an example, and I think we need to think about people with the disease when we discuss these decisions, of two individuals who had both very poor profiles, and one was forced to wait 18 months to get access to a highly effective therapy, and the other one got it straight away. And these are the consequences. So they're both in the public domain. I've asked their permission, and they've both given me their permission to discuss them. One is Ian Rogers. He works for the government. He's a researcher, highly intelligent gentleman. And he developed MS in the early 2000s, and he had 2 attacks. And he came to see me, wanting me to refer him to Canada, to Ottawa, to have a bone marrow transplantation. He'd read the literature, and I said to him, you can't have a bone marrow transplantation, it's too risky. So I sent him to Cambridge, and he was actually enrolled in a clinical trial in Cambridge, and he was due to go and have his asymptomatic dose, and that's when, the week before, the index case of ITP died. So they stopped dosing, and he was told he couldn't have alemtuzumab. So he came back to me, and he was put onto rebuff. And on rebuff, he had 2 major attacks. The second attack left him in a wheelchair, and they restarted this particular trial in Cambridge where they were testing a tolerance strategy to get rid of the neutralizing antibodies. Anyway, he got into the trial at EDSS-7. Anyway, he made a good recovery from those relapses, but he lost the ability to run. He can't run anymore, he can't play tennis, and he's got a dropped foot, so he can't run downstairs. So you may think, well, that's not a big price to pay, okay? Losing your ability to run, walk downstairs quickly, or play tennis. But his whole social life was around his tennis club. The second guy is Tony Johnston, and you may know him, he's a professional golfer. So he had pretty much the same profile, came to me after 2 relapses, and he had a terrible MRI scan. He had ataxia, and he had weakness in a leg, and he had a big spinal cord relapse. I sent him straight to Cambridge, and he was enrolled immediately into the phase 2 alemtuzumab program and got it straight away. Okay, 5 years later, back on the professional circuit playing golf, both these individuals now have been free of disease activity. No relapses, no disease progression. They've actually both improved. Tony Johnston's got an EDSS of probably 1. He gets a little bit of sensory symptoms on a hot day after 18 rounds of golf. That's all his symptoms are. And they're both out now about 7 to 8 years of receiving this therapy. So the difference between Ian and Tony is 18 months delay and 2 relapses. So I think we need to think about the individuals when we make these decisions. And this is just the extension data from another drug, natalizumab, and just to show you that there was a difference, obviously, on exit from the studies in terms of disability. And those people that were on placebo in the pivotal trials never catch up. They always get left with their disability, even though they go on to a highly active therapy. So the message here is once you've acquired this disability from being on a placebo or less effective therapy, you're never going to get it back. So the question is that if you had an option, and this is asking people with the disease, I did this survey in the last week on our blog, asking people with MS, if you had an option for early aggressive treatment, would you choose it over a safer first line? Not everybody wants it, but the majority said they want it. And would you, and who should make the decision regarding MS treatments? The questions were the regulators, payers, neurologists, MSs. And what is quite interesting is that people with the disease would like neurologists and themselves to make the decision, which is why I'd like to thank the EMA for giving us this license, because this is the kind of license we want. Okay, this is the license for alemtuzumab to be used in people with relapsing MS who have active disease, defined clinically. And I love the OR, MRI, and Gordon, I think you're going to address the OR in your talk. So this is the kind of options we'd like to have on the table to offer people with the disease. And then I'd like to say that hopefully this type of data, and I put this up for George, because George always said to me he'd like 12-month confirmed progression rather than 6-month. Hopefully this is going to translate into a delay in secondary progressive, or maybe preventing secondary progressive disease in a proportion of these people with this disease. Okay, and more importantly, if we use this drug early, can we prevent people with MS becoming demented? Thank you very much.